South Africa has recorded over 4,000 new COVID-19 cases and 93 deaths in the past 24 hours. The Health Minister Dr Zweli Mkhize has warned that the third wave is imminent. To date, over 823,000 people have been vaccinated under both the Sisonke Programme and the Pfizer first dose. To give us an update on COVID-19 in South Africa as well as the vaccine rollout, I'm joined now by Executive Director and Editor-in-Chief at Bhekisisa Centre for Health Journalism, Mia Malan. Very good afternoon to you, Mia, and thank you very much for your time today. Let's talk about the vaccination drive that we're currently experiencing and undergoing in South Africa. Is it going according to plan? I did see some international publications describing it as it being in shambles. Would you agree with that?
I would certainly not call it being in shambles, but I would say that we are not up to speed yet. So if you look at the government's targets, the health department set a target that if we want to use up all our vaccines that we will receive in the next 5 to 6 weeks, we need to do 109,000 vaccinations this week each day. And if we look at how many we did yesterday, it was about 66,000. So it's about 60% of that target, which means we're not there yet. But if we look at the past week, we've increased each day with the number of vaccinations. On Monday, we did about 50,000. On Tuesday, 60,000. And on Wednesday, we did 66,000. So the way that the government releases the figures is they give you by just before midnight the figures of the previous day. So we don't yet have figures for Thursday vaccinations. The one that I mentioned, the latest ones are for Wednesday. So I do think we're picking up speed, and I do think there's been glitches with the EVDS system to register for vaccinations, but I don't think it's true that the system isn't working entirely. I think they're trying to sort out those glitches, and we really do need to make sure that we communicate better around the system. I don't think the health department has done a great job of explaining what people must do when they, for instance, don't get an SMS or when they get a wrong appointment from a vaccinator. I've heard of people who have gone to be vaccinated for their first shot. They need to get their second shot 42 days later, and they would then get a completely different date on a piece of paper from a vaccinator. And I think it's very important to communicate around that, because actually the answer to that is that the EVDS is going to send you a SMS that it hasn't done any SMSs for second appointments yet for 42 days, regardless of what that piece of paper says. But those sort of things, when we speak as journalists to the health department, we get the answers, but there's no direct communication from the health department to the public, and I think that's important.
Let's talk about the number of vaccinations we actually need to have administered in order for us to reach herd immunity.
So the government is aiming to vaccinate 40 million people by February next year. And in order for that to happen, we need to stay with the targets, the intermediate targets that the health department has set. And as I've mentioned, we're not there yet. So will we get all the 40 million people that the government wants vaccinated by the end of February? Will we get it done? I think the answer to that is it will be very, very challenging to get it done. We may not be able to make it. But, South Africa is a country of miracles. Let's see what happens. In terms of herd immunity, that is not a given thing if we have vaccinated 2/3 of the country. It depends on how effective these vaccines are in making people who have been vaccinated less able to transmit the virus. If it doesn't reduce your ability to transmit the virus, it will just result in the virus still spreading, but people not falling severely ill. And at the moment, we don't have a lot of data about what is the reduction in transmissibility with COVID vaccines. There's promising data that shows that it's likely that it will happen, but we don't have sure data. So the thing about herd immunity is not a given thing. It is something that we're still figuring out and need more data for.
Talk to us about how it happens, whether one gets a Pfizer vaccine or they get the Johnson & Johnson administered to them.
So first of all, you can't choose which vaccine you're going to get. You're just going to have to take what the place where you're assigned to gives you. So because Pfizer is a little bit harder to store and administer with the 2 doses compared to the 1 dose of J&J, the policy in our country is to generally assign Pfizer doses to urban areas because they have more access to better storage facilities, and it's also easier to track people to come back for their second dose. In rural areas, there are fewer facilities for storage, so the government has assigned J&J doses to rural areas. Now, as you may know, we have no J&J doses in the country that has been released at the moment. And that is one thing that we can't hold the health department responsible for. It has really no control over when those doses will get released. It all depends on investigation that's being done by the US regulator, the Food and Drug Administration, to look at whether there's been any contamination with regards to the main ingredient that the vaccine used, because there were some problems in a US factory. It seems like our batches were not affected at all, but we are not allowed to release those vaccines unless the FDA gives the go-ahead. And it's not just the case in South Africa, it's the case for all J&J vaccines around the world at the moment. And that has obviously set us back quite a bit, because if we were able to have released the 1.1 million already manufactured vaccines that are waiting in Aspen, in the Eastern Cape for us, and that are easier to administer than Pfizer, we would have had a lot more rollouts in rural areas by now.
Is vaccine availability one of the major impending threats for the mass vaccination rollout process?
Well, I think the availability of vaccines have been an issue throughout, since the start of the time when they became available. So yes, that is a major issue. What it does look like is that from after June, from July, August onwards, vaccines may become more available, more easily available to us. And the reason for that is because the US and Europe would have vaccinated a lot of their people and not buy so many vaccines any longer. So hopefully by the time that we get to second doses of Pfizer, you know, the first person was vaccinated on the first batch of people on May 17th. And if you look 42 days after that is towards the end of June. So hopefully by the beginning of July, when we have to start with second doses, there will be more vaccines available. But we do not have control over whether companies deliver their vaccines on time. We can just hope that they do. Mostly in the contracts, it says you can't penalize the companies for delivering the vaccines late, and it all depends on how quickly they can manufacture it.
There have been calls, Mayor, from some who suffer from comorbidities for them to receive priority in the vaccination process. Is this something under consideration?
No, it's definitely not under consideration. So I understand that there's confusion about it, because when the government announced its vaccination program in January, comorbidities was a category to be prioritized. And then that changed along the way, and it was really not well communicated that there was such a change. So at the moment, what we're using to prioritize people is mainly age and also their likelihood of getting infected. So with regards to the likelihood of getting infected, that's why we're starting with health workers, because they're the most vulnerable to infection, because they work with patients, and also because we need them for the third wave to look after patients and also to be vaccinators, to vaccinate people. And that's why you also may have heard of after people who are 60 and older, when we get to people who are 40 and older, we are going to also look at crowded settings, so congregate settings, because people who live in one building are more likely to infect each other when there's a lot of people in a building than just in a small house. So you may ask, why are we using age as the main sort of like indicator as to who we're going to prioritize? The reason for that is a couple of reasons. The main reason is that research has shown us so far that age is the strongest indicator as to whether someone will die or will end up in hospital as a result of COVID. It's an even stronger indicator than comorbidities. The other reason is that a lot of the comorbidities, such as diabetes and hypertension, are age-related. They're more likely to occur among older people than younger people. So if we go by age, we automatically cover quite a large proportion of those comorbidities in any case. The other thing is that a lot of comorbidities are undiagnosed. So a lot of people with diabetes and hypertension don't know they have it. And if we go by comorbidities and not by age, then we may miss some of those comorbidities. And lastly, it's very, very hard to verify a comorbidity. So how are you going to prove to a vaccinator that you have diabetes or hypertension? If you're privileged and you can afford a GP, you could perhaps go and get a certificate, but you know there could be fraud with doctors just giving you a certificate. But if you're poor and you have to go to a public hospital and line up for a certificate, you're at a severe disadvantage. So those are a combination of the reasons why we're using age, because of the research and because it's so much easier to verify. It allows for less cheating than what comorbidities would allow for.
If you could, Mia, talk to us about the dynamics of the gap between taking your first Pfizer vaccine and the second dose, because that is a measure that has shifted recently.
Yes, you are right. So when the efficacy trials were done originally, they measured the efficacy of Pfizer with a 21 day's gap. So in other words, you would receive the Pfizer dose and 21 days later you would receive the other dose. And then you may recall in the UK and in some other countries, there was a lot of debating around, shouldn't you first try to vaccinate as many people as you can with the first dose, because it does already provide some protection, not the full protection, but some protection, and then wait a little bit longer to get the second dose. So research has been done around what happens if you increase that gap between the first and the second dose. And with regards to Pfizer, some studies have shown us that there is really no difference in efficacy and safety between a 21-day gap and a 42-day gap, so that you can, in settings where you have a shortage of vaccines, extend that gap. Some studies have even shown us with Pfizer, particularly among very old people, that the longer the gap, the more the protection that is provided. So there's a study that has shown that if people are 80 and older, the kind of protection that they get from Pfizer is actually more I think it was a 3-month gap actually that they used in that case, that the protection is actually more. But in the case of 42 days, most of the data that we have show us that it's a similar protection of 22 days, than compared to 21 days.
Before I let you go, Mia, very quickly, we are expecting the President to address the nation soon. What do you anticipate will be part of that presentation with regards to COVID-19?
So we have seen cases going up consistently now, and it's indeed imminent with the third wave that we're going to have. So what we need to do is to try and slow down infections. And something that becomes a very big concern when the infections are going up is crowded settings. So people hanging out in groups, essentially. Why is that such an issue? Because the likelihood of someone being infected and then spreading it to everyone else is so much higher at the rate that we're getting infections at the moment than 2 months ago. So we will most likely hear the President announcing measures that reduce the number of people that can be in a group. So churches or funerals, the number of people who can attend that might likely be reduced. And the other thing we can do to slow down infections is to stick to the measures, the social distancing and mask wearing. Now, we know that people are not doing that so well again or any longer. So what can the government do to make us do it? Well, it can probably send a message through increasing a lockdown level that the situation is now very serious. The other third measure that you might not see now, perhaps later, is alcohol sale restrictions. So mainly the alcohol sale restrictions that I have is to reduce or to open up beds for COVID patients. And the people who will fall ill will take 10 to 14 days to fall ill, because that's how long it takes for the infection to be picked up in your body or to emerge on a test or for you to show symptoms. So we may see later that those measures are introduced, or we might see some alcohol sales restrictions, but mild ones, and maybe it being increased in 2 weeks when there are fewer hospital beds.
Mia, we'll leave it, unfortunately, we'll have to leave it at that for this afternoon. Time not on our side, but thank you very much for that comprehensive update as to where we are with COVID-19 in the country. That was Executive Director and Editor-in-Chief at Bhekisisa Center for Health Journalism, Mia Malan.